My name is Sean Stewart, and I am the LeagueSmart manager in New Zealand Rugby League. And we're very grateful and fortunate to have our whanau from New Zealand Rugby join us. And so I would like to introduce some of our guests, or one of our guests, and I think there's another one there as well. Danielle, was that right? Yeah, so there's two. So I'd like to introduce Danielle firstly. Danielle, would you be able to introduce yourself? I guess from a New Zealand Rugby League point of view, Danielle is a research scientist, and please put me in the right direction if I'm wrong, Danielle, but she's been doing plenty of work in the concussion space for New Zealand Rugby. So we're very grateful to have Danielle with us this evening. Did I get that right, Danielle?
No, that's great. No, that's great. Thanks, Sean. Carol Funnel. So I guess, yeah, so I'm definitely not from New Zealand. I'm from Canada and had never seen a rugby game or a rugby league game for that matter till I moved here to New Zealand about 2010. But since then, I can now say I can hold a conversation about rugby, and I know that a hooker is a playing position on the rugby field. So yeah, we're getting there. But yeah, so I guess the focus of what I've done in the past is initially my PhD was focused on developing kind of a neck rehab program for chronic neck pain. But really what we've done, kind of moved into as I've kind of progressed over the last couple of years is in the concussion space. So really focusing on how do we make the game as safe as possible, and potentially when concussions do happen, how do we ensure that our players are well looked after, they're getting the right information, and yeah, that we've kind of got a service that we can wrap around. And that being said, it really leads into very grateful to have Brett Doherty and Kirsten Evans join us today. So I've worked closely with these two for their sins for the last couple of years. So it's been great to have them involved with one of the pilots that we're running in Otago. So Brett's been our GP, who's joining us from MIQ, and he's just got back from the Olympics. So I called him up this morning. So grateful. Thanks for jumping on, Brett. And
thank you,
Kirsten, who's been with great leading kind of one of our probably King's High School in Dunedin, and I think she's just recently moved to Christchurch. So we'll be sad to leave her. But she's been great kind of leading that space for us from a physio's perspective. So really what I try to do is I'll give you a little bit of a quick and dirty about concussion, but then maybe I'll turn it over to Brett and Kirsten just to lead us through kind of their story and what they do in the management, because it's all good for me to tell you, but it's probably better to hear from people who are actually in there doing the work, getting their hands dirty. So Brett, Kirsten, was there anything you guys wanted to add?
No, thank you. Covered it, Danielle. Good job.
Yeah. All good, cool. So I'll kick it off. Sean, can I share my screen, if that'd be okay?
I sure can. Let me make you a host.
Cool.
Here we go.
Cool.
And again, just before you start, Danielle, again, team, if there's any questions or inquiry that sparks in your mind when you during this workshop, please do feel free to excuse me, pop them down in the chat box, and I'll be keeping an eye on the chat box from there.
Can everybody see that all right?
I can see that, so I'm assuming that everyone else can see that.
So hopefully you're getting the presentation view. So yeah, again, thanks for jumping on. So really kind of what we wanted to talk about as is central to a concussion discussion is what is a concussion? And if we're honest, it's probably something that we don't fully understand, and there's a lot of gray area, but kind of the nuts and bolts of, if you think about kind of as you see in this picture, your brain kind of floats inside your skull. And what a concussion is when there's a rapid onset of movement from either a direct hit to the head, so whether they bump heads or you hit the ground, or it can come from a tackle or some sort of event where there's actually no direct impact to the head, but there's a bit of a whiplash that goes on. So what happens in that scenario is you can see kind of the brain's attached to the spinal cord. So when the head moves, it'll bounce and it'll rotate. And when that happens, we've kind of got the brain's made up of these nerve cells that kind of, if you were to put your hands together, it kind of look like these neurons that look like the end of your fingers. And what happens is they communicate by sending neurotransmitters from one nerve cell to the other. And when we shake or twist the brain, what happens is they tend to go through a process whereby they dump all the neurochemicals that they have, or neurotransmitters that they have in those neurons, into the space in between, and that affects how the brain works. So kind of in a nutshell, a brain is a transient impairment of brain function. So, you know, if you get a brain bleed or something more severe, you're stepping out of the realm of what we call a concussion and more into what we call a moderate to severe traumatic brain injury. So a concussion is an impairment to brain function that will usually resolve. And I guess the challenge with a concussion is it can be, you know, minor symptoms from just a headache, and it can happen right away, or it can happen 48 hours after the event, or it could be a range of symptoms where you start to see a personality change, or they're struggling to recall certain things. So, or they become more, there's a change in mood. So there's a whole spectrum of symptoms that can present with a concussion, which sometimes makes it challenging to identify when a concussion's occurred. What we do know in New Zealand is that, particularly for the majority of our concussions in the sport space, tend to happen between the ages of 13 and 18. And within those concussions, that accounts for about 20% of all concussions that happen in New Zealand. And I think Rugby League has a similar kind of recommendation, but for us in New Zealand Rugby, we try and focus on these 4 R's of concussion, because anything more than that, I start to forget what they are. So really what we have is a recognize. So that's really if you suspect a concussion's occurred, so they have any of those symptoms, we kind of focus on how do we get players to recognize them, how do we get our coaches to recognize them, we get that player off the field, that recovery, they go through a graduated return to learn and return to play, and then before they go back to full play, that they're medically cleared to do so. So again, kind of how do you tell? What we do know with the work we've done in the concussion space is that often we see a lot of players that aren't comfortable reporting their own concussion. So we kind of, when we talk about educating players, we say, here's the symptoms of concussion, but really what our focus is on, if you're not going to tell anybody about your concussion, what we try and really promote is how do you identify concussion in your teammates? So this is, we kind of caught through those symptoms about being impaired or dazed, forgetful or clumsy, you know, slurred speech, they can be knocked out. But again, loss of consciousness usually only happens in about 10% of all concussions. So it, you know, being knocked out is a sign of a concussion, but not just the only sign of a concussion. Mood or behavior changes, and often what you'll find is potentially because of that, the dump of those neurotransmitters, often they can't remember what happened before or after the game. So when you're looking, you think somebody's been concussed, there's certain questions that you can ask about what's the score, or what did you eat for dinner last night, and see if that jogs their memory and if they can recall that. So it can sometimes be helpful in determining whether or not somebody's sustained a suspected concussion.
Yeah, Danielle, I just to sort of come in there, I know us at New Zealand Rugby League really like the thought behind that and the process behind keep your mates safe. So yep. Not just making the responsibility of a referee or a manager or a coach. You know, there's lots of roles that are happening on the sideline at game day, but also probably the most powerful thing, I'm not sure if you would agree, but is it coming from your peers, your friends who are playing with you side by side. We really like that sort of train of thought. So something for our for those that are in here and listening and a part of this workshop. It's something that I know League would like to explore a little bit more, because that's huge.
No, for sure. And that's what we've kind of really determined is there's no point if players aren't going to identify their own concussions. And when we went out and we surveyed high school players, about 70% of the players that we surveyed said they wouldn't report their own concussions. So again, you know, there's a number of different ways to skin a cat. So what we're trying to do is, if they're not going to report their own concussion, how can we empower them through? And I suspect it's similar, Sean, in rugby union and rugby league. You've got this strong bond between the players on the field, male or female, this kind of strong kinship that they have between them, and really using that to help kind of focus these messages and talking about, if a player sustains a concussion, this is how you look out for your team, and this is what you can look for. So that's really been the focus of what we've tried to do with our education, is empowering players to look out for each other.
Yeah.
And again, we talk about, looking out, but also being able to know what it feels like, because often a concussion is difficult because it's one of those injuries that you can't really see. So we talk about, have you had a concussion? What did it feel like? And the key thing is, these symptoms don't have to present right away. It can be up to 48 hours later that they appear. And often we'll find as a player sustains a concussion on a Saturday in a game, it's fine. And then Tuesday, first thing in math class, they get this rager of a headache, or, that's when you start to notice it. So it's kind of being aware that these symptoms don't have to come on right away. And I guess kind of what we talk about is the importance of recognizing when a concussion happens. And the key thing for us, and probably for league as well, is concussions aren't just a rugby problem. They happen in all aspects of life, pulling your clothes out of the washing machine, you smack your head on the dryer. But the key thing for us is in rugby union and rugby league, if they sustain a suspected concussion and we don't get them off the field, there is a potential that they get a second impact in that same game, which we start to get into what they call a second impact syndrome, which can be a lot more severe. So it really highlights the importance of recognizing that initial injury and getting them off the field. And, you never want to be in that case where, they take an impact and, there's been a few in the media where it has resulted in loss of life or something along those lines. So we never want to put anybody in that position. So really our focus is recognize it initially, get them off the field, get them into the doctor and be helped. And often we get some pushback because I know, Sean, you guys have that 21, 23-day stand down as we do, where, if you suspect they come off and then they have to do the stand down. But I guess the key thing for us is getting them into that doctor so they can make that diagnosis around whether or not a concussion's been sustained. And then we can go through that graduated return to play, return to learn. And I guess the key thing also to remember here too is that your brain not only controls how you move, but it also controls how you think. So we do know that is if you've sustained a concussion, and it will affect your movement pattern as well. So if you're playing a return earlier before you're fully recovered, you're also, we know from the professional level, you're at an increased risk of a lower limb injury. So it's important to, again, make sure you're fully recovered before you go back to play. These are what we term kind of red flag symptoms. So these get you a free trip straight to emergency. So, if the player reports neck pain that they previously haven't had or any that is unusual, double vision, increasing confusion, repeating vomiting. Sometimes kind of the key we get from this is if they vomit more than once, they should go straight to ED, tingling or numbness in the arms, bad or worsening headaches, and decreasing level of consciousness. So these are the key things you kind of want to remember, because these indicate that it's not a concussion, it's something more severe and you need to be checked out. And often in around these, if there is a loss of consciousness, it's important for your players that, on the scale of bad things happen, a neck injury is worse than a concussion. So whenever there is a loss of consciousness, you want to ensure that the players aren't rolled over, aren't put in the recovery position, that, you keep them in the position they're in and until medical help arrives, or, a physio's there who can take over. So it's really important, if there's a loss of consciousness, we treat it as kind of a neck injury and get them into ED. And again, just for the recovery side, for New Zealand Rugby, if a concussion occurs, there is a stand down period, which I've actually got the wrong stand down period, which is a little bit embarrassing on here, but it's 21 or 23 days. So on day 19, you can go into the doctor, be cleared to contact. On day 20, they could go back and do a contact session. And then if that goes all well, then they can return to play on day 21. And the difference between a 21 and 23 day stand down is that with under the age of 19, we know that brains are still recovering, are still developing, and they take longer to recover. So that's why, particularly for our under 19s, that they will miss 3 weeks of play. So it gives them a chance to ensure that hopefully they're fully recovered by that time frame. But I guess the key is that 21-23 day is a minimum. So again, they have to be medically cleared. So it could be longer if they're still symptomatic at that time point.
Yeah, cool. That was something that I just picking up there. It is, as you mentioned, it's a minimum requirement, and I guess we've got exactly the same graduated return to play.
Yeah.
And there is that resource. So for those that are in the workshop at the moment, that resource sits on our LeagueSmart page at nzrl.co.nz. But it's very similar. And again, you need to be going through those different steps. And if sometimes you may spend a little bit longer on one stage before you progress, but it's and I think it's the same for rugby as well, isn't it?
Yeah.
Yeah.
Cool. And then I guess I'm not going to really speak to these, so I'm just going to glance over them quickly, but probably what I can do is when Brett and Kirsten, and we've got Graham McCrory, who's just joined us as well, one of our doctors in Hawke's Bay, is I'll let them come back. But again, we've worked through kind of a process in around returning to school, because again, your brain controls how you think and how you move. So again, for us, the recommendations, they have to be fully back at school before they can go back to contact training. And then, as you said, Sean, here's the steps that we have that kind of allow for that time frame, so that progression. But I'll probably leave Kirsten to walk you through this, because she'll have more experience walking players through the return to play. Yeah, and then I guess just for us is, again, we talked about at the beginning is that we know that 70% of our players don't report a concussion. So if we focused all our efforts on getting players to report a concussion, and we get a great outcome of that through all our education, I guess the challenge is often we need to step back and look at the big picture. When we talk about the management of concussion, it is around how do we get coaches to recognize, how do we, provide first aid at the time of injury, the importance of doctors and helping support them through that diagnosis and medical clearance pathway, ensuring that the doctors and the physios have access to the right information and guidelines for our graduated return to play, return to learn. And I do believe, Sean, you guys also run a blue card kind of system where we, referee can issue a blue card and remove a player. And then we've got kind of protocols and policies around weight banding, introduction of tackle, that kind of takes what we call is a social ecological framework to help support the welfare of a player, but really talks about, if we focus all our eggs in one basket, potentially don't improve the care, because there's a number of different facets that feed into that. So the importance of taking a step back and looking at the big picture. And what we've tried to do with our community concussion initiative is not really do a great job anywhere, but hopefully do an okay job in a number of different areas, so that we can, better support the players so that they're not slipping through the cracks at some stage. There's definitely still a lot we can do in that area, but hopefully with, creating the awareness and really emphasizing the importance that everybody's involved in looking after a player, that we can get to that stage. And this is just kind of our pathway.
I was just going to comment just before we move on, that we do have, as you've got the blue card, we do have, we have been trialing at our national competitions. So so we're probably a little bit behind, and we're just trialing the different ways that we can assess or I guess implement a blue card system. So we have tried it in our national premiership last year, and we're also adopting it for our secondary school competition. But as yet, nothing is formally across the nation at the moment in terms of grassroots games. So, but it is. Awesome. I mean, that's some conversations that maybe we could. At the end, when we're sort of reviewing or looking at what rugby has done, what we might be able to learn from processes like the blue card, and that we can save that maybe for the end if we've got some time.
Sean, can I ask, so Graham McCrory here, one of the doctors involved, when you're talking about the blue card type system, is that the HIA that we do in rugby at the side of the pitch, at the more senior level, at the sort of national provincial level, Super Rugby, and then at the international?
Yeah, at the moment, it is just, it's been at our representative, so it has been at regional level.
So you are doing an HIA type assessment, yeah.
Type assessment with with proper medical staff there, yeah, which is why we haven't implemented anything further at the grassroots level.
Yeah.
But keen to learn around what are some things that have worked well.
Cool. Okay, so I'll just go through to the next one. I'm just conscious of time, and I probably want to. I'll probably end the presentation after this slide, but there is, as per usual, I've got way too much information on my slides. But if people want it, I'll send it out after, and I can speak to it if it comes up. But this is just the process that we've been piloting. So this is Brett and Graham and Kirsten have been involved in this process over the last 3 years. And really what it is trying to take, I guess, the blue card and kind of the process that happens in our professional space and try and ensure how do we implement that at a community level. So what we've tried to do is develop and use some technology to help support this. So what we have in the blue square here is kind of our preseason, as we focus on education, sessions for our players, our parents, our coaches. If you pop onto the rugby toolbox, we have different online education sessions for parents, coaches, for all those stakeholders that talk about concussion education and the recognition. We've also developed kind of, I'm not sure if people are familiar with the SCAT, which is a sport concussion assessment tool that's kind of currently is the gold standard for the assessment of concussion that was developed internationally. But I guess the challenge is it works very well in a professional sport or a sports medicine clinic, but it's a little bit more, is not practical to implement in primary care. So when you go in to see your GP. So what we did is working with people like Brett and Graham, we modified this to try and shorten it into something that works within primary care. So what happens here is if a player sustains a suspected concussion, we have individuals in the team who are set up on an app. So for example, Kirsten will speak to the fact that after a game, she may log a concussion for one of the players on her team. When she does that, it'll take her through a process that says, here's the red flags. You don't need to remember them. If you tick any of these boxes, we'll get a pop-up message that says this player needs to go in and see a doctor right away. If he doesn't have any red flags, it captures some more information, which will be sent through to the doctor when the player goes in to see him. But kind of the cool thing is in the app, it auto-generates some emails that goes out to players, parents, and coaches saying, Danielle ran into a goalpost, not doing so well, so we pulled her off the field for a suspected concussion. In the email that goes to the player and the parent, there's a code that goes with that. So what happens then is that code, when my parents take me into the concussion to see the doctor, I give the doctor that code, and that doctor is then able to access my baseline and which won't be diagnostic, but how potentially help support their decisions on whether or not they think I've sustained a concussion or, I've just got really bad coordination and, maybe should give up rugby. So really what it is doing with that assessment is we give them a process to follow. They then make a decision. I'm concussed. Then I go through that graduated return to play, return to learn. When I get to the stage in my graduated return to learn where I've completed a non-contact session and I have no symptoms after that, I can then go in for a medical clearance. So I go back to the doctor, they use the same access word and code, and then they repeat that assessment and then they determine, yeah, I'm good to go. And emails goes out to those same people saying, Danielle's been medically cleared, she can return to contact training, or no, Danielle's still not doing well, she needs some more time off. I can't go back to contact training. So it kind of takes hopefully what is a gold standard practice, but kind of modifies it for that community sphere.
Nice.
So
I guess the referral that goes straight to the doctor, is that just the normal GP, or does New Zealand Rugby have?
So it is just a normal GP. We do with this process is what we found is it's too long to do in 15 minutes. So we offer through this process, we do offer 30-minute appointments, and we're working with ACC TBI strategy to see if that can be something that ACC can actually roll out nationally. But as part of that 30-minute assessment, we're working with nurses in the clinic who potentially can do the first 15 minutes, and then the doctor can do the second 15, where they can do the physical exam and then go through an education process. But we're learning to more collaboration between physios and doctors, which I think we run a concussion clinic on a Monday night in Dunedin, which I'm currently sitting at, but and Kirsten and Brett can give you a sense on potentially how that works. But really the key thing for us is they're not being referred into the ACC concussion service. What we want to try and do is do a good job of managing these people in the first 4 weeks, getting them education, make sure they're getting the right help, get them into a physio where they need to be seen, and then see how they're doing. If they're not doing well at that 4 weeks, then we can refer them into the service right away. So yeah, it's trying to do a good job managing them really well acutely, so that, you know, hopefully they don't get to a stage where they need additional assistance or still struggling at 4 weeks time.
That's great.
Yeah, so really kind of from that, overall, our goals are for this project of this. Players are removed, they're referred to a GP and for a medical diagnosis when it happens, and that prior to them going back to contact training, they're medically cleared. I'll keep going just because it tells you about how we're currently. So I guess in 2018, we had 2,500 concussions that were reported through to ACC. When we look at the blue card system, we captured about 19% of those concussions with the blue card. In 2020, just to give you a comparison, in those 3 PUs, through the logging of the app, we captured 98% of those concussions.
Wow.
And of those concussions, we know that 81% of them were medically cleared. So if we go back to 2018, we only know that 19% of those 2,500 concussions were medically cleared. Hopefully there's a lot more, but hand on heart, we can only say that 19% were, versus 2020, where through this pilot and the work that Brett and Kirsten and Graham have been involved in, we've been really able to kind of try and document that a lot better. So I'm just going to stop there and yeah, turn it over to this crew that I brought on, Rockstar. So maybe turn it over to what I thought Brett and Graham, if it works, is maybe if you guys want to speak to kind of a medical diagnosis, and then Kirsten, if you want to jump in and just maybe speak to how you manage a player through that stage in between kind of that recognition and then through the graduated return to play, return to learn. And then Graham and Brett, if we jump in for the medical clearance, that would be awesome if that works for you guys.
Yep, no problem.
Graham, you want to go first?
Yeah, welcome back from Japan, Brett.
Thank you.
So I've been really impressed and encouraged by using the tool that we've got and what we've been able to do. I think there's a big thing from the athletes. They come in and they're all sort of, oh, I've got concussion. What happens now? Where do I go? What do I do? Am I going to get better? And what I've realized is that, you know, most people will get better from their concussion within about 3 weeks. And it's really reassuring to them to let them know that. I think also what I find really helpful is having a close liaison with a group of physiotherapists who tend to be my first port of call for help, to collaborate and work with, to help the athlete get better. And not just athlete, but the old woman who's fallen down the steps and banged her head and she's got a concussion. You know, physios can really help here. We've one issue with ACC in that physios aren't, I think, still allowed to claim from ACC for a lot of the work that they do with the concussion patients. So they're having to treat everybody for their neck sprain, which does usually go along with the concussion. But what I've found, and having listened to and spoken to a couple of people who are on the International Sports Concussion Group that developed the SCAT have spoken to us in Hawke's Bay that the best way to recover from concussion for most people, especially for athletes, is exercise. And that's really encouraging for most of the athletes who think, oh no, I'm stuck, I can't do anything, I'm stuck for 3 weeks, I have to sit on my bum and do nothing. And encourage them back into exercise up to a point before they get symptoms has been really encouraging. And the physios can take them through the way to do that in a safe, organized way so that they return to their full exercise and they come back to me and they know when to come back. They know they're better most of the time. And they know they'll come back to me before if they're not well and need more help. And I can hopefully help to coordinate that. And they come back to me when they know they're better after their 21, 23 days for their clearance. And
so Graham, so I might just squeeze in there.
Yep.
Thanks again for your time and for your knowledge. I guess I'm just looking at the chat, and while we're on that, there was a question: do you require players to have a medical clearance prior to returning to training, then contact, then play? What? Yeah.
So training, the sheet that Danielle showed up earlier with the different levels on it takes you through a graduated return to play. I'm also a school doctor at a private boarding school here, where every kid thinks they're actually All Blacks already. And it's quite difficult letting them know that actually this brain up here is more important for you guys to learn things rather than to play rugby. I'm trying to calm them down from that attitude. 3 weeks, this is far too long. I can't do it. I have to do nothing for 3 weeks. So it's really important that they get the exercise, that they get exercise up to not getting any symptoms. And in our assessment tool, there's 23 different symptoms that we will ask about, and we want them to grade them from mild, moderate, or severe, or not at all. And the symptoms, a big range of things from headaches to vomiting to concentration to sleep problems to dislike of light and sound. So if any of these things are happening while they're exercising, they're doing too much. But the physios are able to take them through a protocol that's been devised in Buffalo in New York by a group there led by a guy, Dr. John Leddy, who's part of the SCAT group, where they put them on a treadmill or an exercise cycle and get them up until they're just getting symptoms, and then they check their heart rate. And that is their maximum tolerated heart rate. So the way to recover is to exercise at a heart rate of 80 to 90% of that for 20 minutes a day. And that, so you're not getting symptoms, but you're getting your exercise up to the maximum you can tolerate. And that'll increase as time goes on through the 3 weeks. So they're really encouraged that they're able to actually get out and work. So they're not, and exercise, they're not assessed before they get exercise. Well, they're assessed by the physio. I'll be taking the physio and say, listen, this guy, moderate concussion symptoms, let's see how he goes on the exercise cycle or treadmill. And they will do that, and then they start their exercise. Once they get up to a level where they're up to doing full passing drills, running drills, they need to be doing up to maximum full physical exertion without any contact before I can clear them. So they need to be right up to that level. So they're back to their training squad, they're back doing the running drills, they're back doing the sort of, I was in leagues pretty much the same, so little quads and passing drills and having to think at the same time as moving. Speaking to the All Blacks doc and physio a couple of weeks ago, they actually get them back into scrums beforehand. Now scrums and rugby unions a bit more head contact than the league, and I'm surprised that they actually let them do that. I'm not suggesting they get into scrums. Maybe in league you could, because they're a bit tame. Anyway, but really before any potential contact, and it's not just back to rugby. There's no soccer, no basketball, no netball. All these things are potential hockey. They're all potential contact. So it's important to let the kids know, or the from the school or the players, whoever, know that you're going to get better, but just work through the process. And we've got a good process there. I saw a question came up there earlier about, do they lie about the symptoms? The 14-year-old already All Black usually does, but they've also, we find that at sometimes at the baseline assessment, they can sometimes underplay the symptoms, so that whenever they do get concussion, it doesn't look as bad. But there are various ways when we're examining them that we can look at things like their eye movements and things, and dizziness and different things to assess them, and they can't really lie about that.
Cool.
So I might be looking at these. I'm missing some of these questions I was picking up on.
That's okay, Graham. That's awesome. Brett, was there anything you wanted to add to that?
Yep. I think one of the things, my experience with Danielle, your pilot we've been doing at Dunedin, we have the luxury of having an alliance with some really great physios. We're starting to get into the high schools, et cetera. And so just to run through, the value of having a doctor at that first visit is to make sure that the patient doesn't have more than a concussion. They don't have a broken neck, bleeding the brain, things like that. And then there is an absolute ton of education and support, as Graham was going over, that is important in getting this patient as better, as fast and as safely as possible. I think we do a really good job down in Dunedin with safe removal from play. I think we do a good job with safe return to play. And we're really starting to work hard on that middle portion of, how, especially with high schoolers, working with the schools, making sure we go over and individualize which each patient we see, right? What do you do for training? What do you do for gymming? Those kind of things. And you, as Graham was saying, we emphasize early active treatment because there is really good evidence that it nudges them towards a quicker recovery. And really the bottom line is, aside taking out the context of sport, is the concussion has a huge impact on this person's life while they're experiencing it. Yes, they might get better, but they got to go to work, they got to go to school, they got other people they need to look after. Those kind of things really do matter. And so those are the kind of things we go over in the appointment as well. Remember that Graham and I have somewhat drunk the Kool-Aid. We're heavily involved in this. And I'm not sure how much we can take for granted that this is the kind of discussion you'll have with your home GP. So it is really important, as you were starting off the discussion, to emphasize that notion of community, of looking after each other, because we just got, the doctor may not know that they're supposed to link that patient up with a physio or, talk to the school or that kind of thing. And those are the things to help everybody to understand are necessary. It's a process that takes a while. It gets into your local culture after a while. And Danielle's been doing this for a number of years, and I can see the difference year in, year out. We're really getting into a grassroots type of orientation.
Yeah, just a question, I guess, within that, sorry, is obviously Dunedin's had some focus. I am curious, and Danielle, you might be able to speak to this or someone else, but how have you found at that community level it being accepted, the protocols or the different, the things with the app, getting baseline, that's.
So kind of, I definitely, probably the best person to answer this is kind of Kirsten. I might throw it to you because I do know Kirsten works with one of our high schools, which are notoriously a challenging group to work with, from the first 15 down to your under 15s, just because you've got the compliance. But to answer Sean, really the value that people have said when they talk about this process, and there's always learning experiences. So, it has evolved each year based on the feedback from people that we're working with. And I think that's really key to the success of the program we've had. But really, I think the value of what we've done is we've made it really clear that there's a process that happens for every concussion that happens in a game or training. So it's very clear. there's no kind of gray where it's just very black and white. This is a process you follow for a concussion. I think that really helps keep it clear for people. So Kirsten, I know you've got a lot of experience with the gray area, so I'll maybe throw to you.
Yeah, I think obviously I work with schoolboy level, so I am in that really tricky population where the boys would much rather be out on the field than having a stand down. But I guess if we take it back 3 years before we started this, when they used to just go to their GP, half the concussions weren't getting picked up, and we kind of get a note back saying 3 weeks stand down with no guidance or anything. And so now it's so different. But I think probably the first year that we did the pilot, we had quite a lot of pushback from people being like, oh, it's just a wee head knock, like, that kind of she'll be right New Zealand attitude that definitely is quite prevalent down in the south. But I think that now, like with the education sessions, and we've got the same coaches and management team like year after year, I think players and everyone involved is a lot more understanding, I guess, and they definitely respect the decision making. And I think it's just I guess it's everyone's putting their work into it and trying to put your best foot forward and be confident in your decision. So if I'm calling a player off the field for a head knock, my decision's not challenged. It definitely was challenged back at the start in the first year. And I think that that's where that community aspect comes in, and everyone that's coaches and stuff that works with the team, like you've got a great level of respect from the players and the parents and the community anyway. So I think if you don't second guess yourself, then your community shouldn't second guess you either.
Yeah, nice.
Yeah,
Kirsten, do you want to maybe speak to, sorry, Sean, just because I know a lot of people with the process about how you would, the steps, like it might be helpful. Here, I'll pull up that graduated return to play, but maybe if you want to walk us through how you progress somebody through that, just maybe helpful.
Right. Open this up. Okay, so essentially you have to excuse my voice, team. I'm losing my voice just a little bit. So with a schoolboy level, we've kind of got a double whammy here where we've got players that want to get back on the field. Not all of them just play rugby. Most of them will play 2 or 3 sports at a time. And we've also got them getting back to school. So step one, once the concussion's been recognised, is getting them into concussion clinics, or the GP in lots of people's cases, and then sitting down with the player and making a plan. So some people manage school from the first day, no problems, and that's fine. We start moving through that graduated return to play. But the players that aren't coping to get through a single lesson, that's where we really have to go back to kind of this graduated return to learning. And you'll kind of see here like the things with the headaches, dizziness and fatigue. And I know the docs kind of spoke to this, that not everyone has the same concussion symptoms. And essentially the main thing that's probably worked with the schoolboys is having regular brain breaks. And I work in concussion service myself anyway for ACC, and brain breaks are fantastic for helping them get back and just gradually building up. If they can't get through schoolwork and they can't get through a full day of school, they're definitely not ready to return to the field. I think they're, like when we're returning them to exercise and that kind of thing, we definitely will be doing that from day dot anyway, but then we get, a little bit, your priority kind of changes based on how they're presenting. So this one here, so all the players that I work with are under 19, so they have a little bit of a longer stand down. So initially that mental and physical rest of 2 days, we're generally getting them out walking. It's not really physically exerting, but we do know that, symptoms allowing that helps their recovery kind of push on a little bit. Those first couple of weeks is really getting into that aerobic exercise. They might be getting on a bike, going out for a bit of a jog, pretty much symptom guided. And in that bit there, just a note, we've found that players that return to the team environment quicker do better. So rather than having a concussed player and leaving them out of the team, and because they can only say go on a light run or something like that, they generally take longer, and it's not as good for their mental health either. So we prefer to get them back with the team sooner, and they'll just do their adjusted activity same as any other injured player that's with the team anyway. After they've kind of passed the light to moderate exercise and they're happy with some running drills and kind of basic passing drills and that kind of thing. Then we move on to non-contact, assuming that at this point they're not flaring their symptoms and they're progressing through as expected. That might just be passing, catching, running through some plays. Definitely when they're learning new plays and things, that can be quite a good point just to figure out if they are able to cognitively keep up. Once they're past their non-contact, down in Dunedin here, they're normally into the concussion clinic again to see a doctor to be cleared for contact training. And I know someone did ask a question about if they have to be cleared at every stage. And I think that in Dunedin, we're really, really good at communicating with the doctors anyway. So they see the doctor at the start to get recognised that, yes, this is a concussion. And then the physios or whoever's with the team kind of manages it. And then when we reach the point and they're ready to return to contact again, we liaise again with the doctor and get that clearance. Once they've got that clearance, they generally then go full contact practice for 2 days and then they return to play. So it is a process. The players that I've worked with know it reasonably well, and once you've done it a couple of times, it is actually quite simple.
Yeah. Going back to game day, Kirsten, did have a question, you might have seen it, is, or it might be Danielle might be able to answer this. How, in terms of the referee's responsibility, it's quite a lot of responsibility with the blue card. So are you able to comment on what expectations there are of the ref and if there's any learning that needs to be done there? Or
I think from what I understand, Danielle might be able to answer this better than me, but the ref's in the same position that I'm in as a physio. So as the doc said, like, I can't diagnose a concussion, but I can recognise a suspected head knock. So when I remove a player, it's for a suspected head knock, not for an actual concussion, because obviously I can't medically diagnose. And so in that position as well, the refs in Dunedin, when they're removing them with a blue card, that's them with a suspected head knock or a suspected concussion as well, and then they go through our system. So I think it's more, rather than expecting them to be able to take it from a medical perspective, is kind of giving them the same side as us. I think just being able to recognise.
Yeah, and I think it's important that the referee, the coach, the physio, whoever, is overly cautious. And if they're suspected at all, get the player off. Don't let them play on, and they get them assessed. And maybe a few days later, but get them assessed. You know, it's not going to make a big difference if you overdiagnose a few, because you don't want to miss some.
Yeah. So priority is player safety, isn't it?
Yeah, and that's what I said at the start, the 4 or 5 hours, I think it's 9 hours, but the recognise and remove, recognise the concussion, remove from play, and then go into recovery, rehabilitate and return. That's 5.
Yeah. So kind of our policy for the blue card is a referee has to witness a player displaying the symptom of a concussion, and then they can issue a blue card. But I guess and then I did see that there's a question around the stand down. So the stand down period starts from the day of injury. So your day 1 is the day that the suspected concussion occurred. And the key for us is going back to that kind of that slide where we had this community model, is that, it is a lot of weight on the referees that potentially are making a decision which takes a player out of a game for 3 weeks, which is not a great position to be put in. But really, I think from a community's perspective, they're looking out for a player safety, and it's really important that is a good thing. They're taking ownership, and it's trying to take that player safety realm even wider. And that's currently, we're in discussions right now to see if we can open up the blue card so that a physio or a coach for their team can issue a blue card for any of those players. So really, instead of trying to see it as a bad thing, it's really, you're looking after player safety, and it's taking it out of just, the player disclosing their own symptoms to a bigger team to help support. And I think, the great thing about that is everybody's taking a bit of a role in that player safety to keep everybody safe.
Yeah,
Absolutely.
and Danielle, I think also like obviously grassroots level, you know, like we can't do this by ourselves. Like not every team has a physio, not every team has a doctor. Sometimes you just, you know, you've got a dad that's looking after the team. So I think that like we've got to just respect that not everyone has a medical background, and that whole recognize and remove is the safest option without, you know, needing to know too much more than that's a suspected head knot, let's remove them, and then the GP can help guide from there as well.
Yeah.
If you look at the suspected head knot at the professional level, you know, the match day doctor is looking at the screen and he is deciding, is that player maybe staggering a little bit, or is he a bit slow getting up, or he's disorientated, get him off in this assessment. Now that's slightly different than doing the HIA on the day with the doctor there. But it's the same thing at community level, that is that player just not quite right? Is there something wrong, as in they're running in the wrong direction? That's maybe a clue. But you know, there's various clues that people will sort of think, yep, there's something not right here, let's get them off.
Graham, you bring up a good point, and I am conscious of time as well.
Yep.
But Graham, you bring up a good point that I would like to sort of highlight, was around the differences between professional and our audience here is going to be at grassroots, volunteer, administration level. Can you speak to why we do see some professional players coming back earlier, and then what? Because I guess want to paint the picture that at the community level, we potentially don't have all of the expertise.
One thing, as I said earlier, most of the guys at the community level are not going to become professional rugby players or league players, and therefore what's inside their head is really important to make sure it's there to learn, to work, to earn a living, etc., etc. And I suppose there is a certain these guys at professional level, they are earning a living doing this, and they're still put through a significant concussion protocol. You know, in rugby, when they get taken off, they go through the HIA1, which is a 10-minute assessment that they're allowed to substitute a player for while that's being done. And if they clear that, they can go back on. And that again is compared with baseline assessment. If they don't clear that, then they get HIA level 2, usually done by their own team doctor, and then an HIA level 3 within a couple of days. So there's a real sort of close watch. These players have got the full support of a doctor, a physio, a team of physios, and lots of other people when they're at that professional level. So they are being monitored much more closely, and they can be cleared earlier because it's their job at the end of the day. One of the things we have to do before we will clear somebody for a concussion to go back to contact is they must be back fully at work or back fully at school with no problems. And I had one guy, for instance, who had a concussion at rugby, and he was absolutely fine, but for weeks and weeks he had a slight double vision when he was looking to one side. And I couldn't clear him he was absolutely fine otherwise, but I couldn't clear him to go back to work because he was a roofer, and I didn't want him falling off the roof because he got double vision when he looked in a certain direction. I think he got quite dizzy as well. So, you know, it's all within context of what they do, but they have to be back at work or back at school fully before they can get cleared to get back to take another lump out of their head again.
Yeah, really appreciate that. And I guess in terms of the league game, NRL, you know, our community can sometimes watch the games and see particular actions, and then next minute the player's either back a week or two later, and the expectation is that so we can get back faster. I guess what we're highlighting.
It happened in rugby union 2 or 3 years ago. One of the All Blacks, Ryan Crotty, he was off almost every second week for a concussion, but he was able to get back, and that's beyond my level of knowledge and expertise.
But I guess at our community level, we absolutely, as everyone has spoken tonight, is we do follow the 4 R's in rugby league as well, and that's the big message. And I really love the I guess the culture beliefs and ideas behind making those decisions, and as a community looking after each and every one of our, any participant. And so, New Zealand Rugby has done a great job in that, and I know that we are adopting a lot of those as well, particularly at our grassroots level. So,
Look, Sean, feel free to get in touch at any time if you need a discussion or chat or anything.
Yeah, absolutely. Hey, look, I know that I could talk about this for another hour. I can talk all day, but I want to make sure that we get the key points across. So maybe for the next 5 minutes, we'll start to close up, Danielle and Graham and Brett and Kirsten, just for our workshop. I did have a couple of questions. I'm just going to make sure that we've ticked them all off. So I'll give you guys a bit of a second, because what I would like to do is wrap up key points moving forward. I know that this is the most I've had on a workshop, so there's a lot of interest and there's a big appetite in our community, in our rugby league community, for concussion, and this is the reason why we are having this concussion discussion. Is as they go through LeagueSmart, they give us feedback, and a lot of it is around education and a bit more knowledge around concussion and what to do. So, I'll just make sure I've answered all our questions.
Yeah, and Sean, just one thing I did have that I might want to pick up is one thing that we do notice for the difference between males and female games is I just wanted to highlight that, because I know there's a small but probably growing cohort of women that are playing league, is that when often we see females tend to have less medical support than our males teams. So I think if you are involved in coaching or managing a female team, really ensuring that you are pretty comfortable around that graduated return to learn, return to play guidelines, because often there isn't a medical person there to help with the advice. And I guess, the key thing is, when you're going through that, is you think about your brain controlling two things: how you think and how you move. First, get them moving, increase the speed of that moving, making sure that they don't get symptoms when they move. And then you get into the non-contact, whereas it has some thinking and some moving, because you got to pass, run plays, and then get them back into a doctor before they go back to contact. But so really highlighting for those with female teams, it's really important that you are a little bit more confident, because we know there's less medical support. Often too, our females state that they're more uncomfortable around returning to contact training after a concussion. So I think if you're helping return a player to contact after having sustained a concussion, spending a little bit more time working on tackle technique and ensuring correct body position and things like that become really important. And the other kind of difference that we've noticed is, particularly for our Maori or Pacifica population, that often we don't see that they access care a lot more. They're less likely to go in and see a doctor. So really trying to help encourage or reducing the barriers to getting those players into a doctor is really important. But also, we know school nurses are really valuable at the same time. So, if you're with a team, trying to link your school nurses up with the right guidings on how returning to learn or returning to sport, just so that we do know that they do access care less often. So trying to get that information in from other areas is really important.
Yeah. And
just to add to that, Danielle, just to add to that, there's a lot of evidence to say that female brains are more susceptible to concussions, so we need to be extra cautious. And when it comes to age groups, that's why we have the longer stand down for younger, but around about age 14, 15, and especially 14, 15-year-old females are the most susceptible to concussions, so we need to be extra cautious.
Thank you very much. Brett or Kirsten, would you like to sort of summarize or add anything to sort of summarizing what we've spoken about tonight?
Very good.
Go ahead, Kirsten.
Cool. So I think probably main thing, just wrapping it up. So recognizing concussion, know your team, you know how they play, you know when someone comes out of a tackle or a scrum or anything like that, and they suddenly have no idea what's going on. That's a really key indicator. And just getting that community aspect going. So I think it's going to be lots of outreaching into your communities and knowing who you have available, knowing who's there. Like I know in Dunedin, I can just call Brett up or Helen up down there, and they help me out. So I think, yeah, just start reaching out.
Fantastic. Thank you.
Yep. I mean, I can't emphasize enough the importance of all that community around people. And, you know, I consider myself as the doctor, the least important person in that process. The physio, the school, even, you know, the workplace is where people, I think, get the support they need and get, you know, I can help them with kind of giving them a game plan, but those barriers are removed and the care is delivered by other people. So yeah, that community aspect, that manaki is really, really important.
Awesome. Thank you, Brett. Danielle, Graham or Danielle,
Yeah. Graham, go for it if there's anything else.
No, not really.
Yeah.
I think, no, I'd say happy to be involved in any way we can. There is probably still, although there's been talk about there's a lack of sort of understanding within the community, we have to be aware that a lot of GPs aren't fully aware of concussion, how to manage it. I've been very privileged to be involved in this group, so I do have more of an inside knowledge, but even our own urgent care in the health centre I work in have missed 2 concussions this week, one of whom I have seen and referring him straight to the concussion service through ACC because he's highly symptomatic, and he was just put down as a head knock in a rugby game. So we have to be aware that there's still a lot of concussions being missed potentially.
Yeah, and I think the kind of
not
the
to end on a
message,
negative note.
No, the take-home message for me is I think we're moving in the right direction, and I guess kind of the key is that kind of going back to our 3 primary goals is get the players off the field, get them into a doctor for a diagnosis. Help work with a physio or school nurse to help support their recovery back to school and learning. And then when they're ready to go back to contact training and sport, make sure they're medically cleared. There is, I guess, Sean will be aware, is the work we are done in next year in North Harbour. We're looking to pilot it across, working in a couple of, I think, 10 or 15 schools in North Harbour and trying to see how we can use the system that we've developed in rugby in other sports. So hopefully, you know, if next year there's interest, we can share how that's gone. But I guess we've developed a system in rugby, but really, as you can see with the 3 lovely people I have on this call, is we really just are concerned about making sure that everybody has an opportunity to play the sports they love and do it safely. So really our goal is to develop something that not only works in rugby, that works across sports and just keeps everybody, nothing we've done is rocket science, but it's really just trying to use technology to help support that management process and widening the circle of trust so that, you know, everybody's across what's happening. Is really kind of the goal of what we've done, is trying to ensure that, you know, when players come off, everybody knows that a suspected concussion has happened. They can get into a doctor and they can get medically cleared before they go back. So it's just kind of keeping a lot of baskets in the air and ensuring hopefully that we catch as many eggs as we can when they come down.
Yeah. Well, look, I through the work that I've been doing through LeagueSmart and I guess the concussion space is only one part of Rugby Smart and LeagueSmart and injury prevention, but the work that has been going on, and I full-heartedly also tautoko the work that has been going and the progress that has been made over the years, and that's coming from someone who has had far more concussions than he should have had. So look, I really appreciate the time the time and resources, and I think it's just on a more of a spiritual level, the actual essence of looking after all of our people, and that's, you know, having you guys join us on this workshop, really being leaders of collaboration with other sports organizations, really goes to show that we're all trying to share as much information as we can, because it's our people. It's our people at the end that we've got a duty of care for everyone, and so I really appreciate that. I really love the work that you guys are doing, and I'm sure that everyone who's watching this feels that as well. I'm getting a bit emotional, but I'm really passionate about this, obviously, because I have personal experience myself. So I do want to congratulate you on the work that's been done so far, and obviously the progress that working together. And if there is anything that we can do to help support that, then obviously on behalf of sort of myself and New Zealand Rugby League, we'd be more than happy, and our community that are listening in as well. So I just want to also thank all those that are in the workshop as well, all our volunteers out there, both rugby and rugby league, and any sport actually, because we are fortunate. We are in fortunate positions that we are in employment to be able to do this. But there's, you know, our sports, our communities don't survive without volunteers and those that are dedicating their own time and effort to the space. So thank you to all those that are tuning in as well. That's all we've got, because I will finish on a karakia if that's if that's all us.
Cool. Well, that sounds good. And Sean, if there's anybody who wants to chat after, I'm happy to stay on for a few minutes and can answer any questions if there anybody wants to have a chat. I'm sure if Brett and Graham or Kristen have specific questions, if they're able to stay, I'm sure they wouldn't mind, or I could send on questions to them specifically.
You're opening up Pandora's box there, aren't you? Oh, you really want to be here for another 2 hours?
I'm just trying to avoid going back to the clinic.
I'm getting my dinner.
Yeah. Well, I'll finish with the karakia, and then for those that do have any questions, please stay behind, and I'll also hang around as well. So we'll bow our hands. Unuhia, unuhia, unuhia ki te uru tapu nui, kia wātea, kia māmama, te ngākau, te tinana, te wairua, ki te ara tangata, ko iho, rae rongo, whakairihia ake e kirunga. Kia tina, huie, taiki. All right. What I might do is if there's a few people, looks like there's a few people still online. If there's any questions that you'd like to ask, please feel free to chuck your video on, or and throw out a question to our panel who have kindly stayed behind.
Danielle, Alan Jackson here, mate. How are you?
Good, how are you?
Good, thank you. Really interested. Just, you know, the way your program and how you record all the concussions and goes through the process of going to the doctor and then the physio and then and getting cleared, and the emails go to everyone else, because a lot of our youth play both codes.
Yep.
Would it, you know, like, because I know some kids that'll play rugby on Saturday and might suffer a knock, but will front up to play rugby league on Sunday, or they'll get a knock on Wednesday and play basketball on Friday night, and then try and play rugby union on Saturday. So they're very busy people. Would there be any, I suppose, modern technology? Would there be any way that we could collaborate with? Because I know that I see now on the bottom of the thing, it went to the rugby, the district or the rugby union.
Yeah, so I guess what we're working on, Alan, is I guess next year we're trying a pilot in North Harbour where we'll have we'll try it in a cross code, so it'll be kind of dictated by the school and capture all the sports within that school. So I guess the goal will be to explore whether or not that works in rugby league, in netball, in cricket, in field hockey, so to try it cross sports. So there is that communication that if Danielle sustains a concussion and playing netball, that I can't turn around on Saturday and show up to play, you know, 7s or 10s or 15 rugby there. So it kind of, that communication goes across the sport. I guess the challenge we have is currently is how people register for their various sport organizations, because I guess what we have to do from our ends is the app we're using is called CSX, but we need to get a team list through, uploaded into the app, which is a bit of a faffing around. So what we're trying to look at is with the schools and the way students register to play, that it's similar across sports, so we can pull all that information together. So it's kind of the non-sexy IT version of how do we get this to work. But yeah, it's, and I fully agree with you. It's trying to create something that works across all the sports.
Thank you.
I guess to speak to that, I know that we've sort of thought about, I know that rugby uses the CRM that you use for registering players is the same as that we have for rugby league. However, I guess it's around the privacy issues that we can't, if we flag someone in rugby league, ideally we'd be like to flag them, you know, that flag would carry across to other sports. But yeah, certainly a good food for thought moving forward.
And what about the horse they ride at the weekend and then fall off that?
Yeah.
Yeah.
I'm saying that I'm also a chief medical advisor for equestrian sport New Zealand, which we can control in competitions but not outside of. So
yeah, no, for sure. But yeah, no, it's challenged, but I think is really important on how do we kind of manage those players across all the sports.
Yeah,
for sure. Was there any other questions?
I know I've got a direct message here, but I might respond to that. And that was just around the concussion app, which is, yeah. So I guess, yeah, I'm quite interested in finding out more around that. So that might be a conversation that we can have later on down the, well, yeah.
Yeah, no, for sure. And it's something, I guess, because we have a license with the CSX to use it specifically for rugby, but I guess with the ACC pile, we'll open it up. But, you know, if you wanted to use it wider for rugby league, I'm happy to facilitate that conversation about if that's something like that's feasible. And I guess what we've learned with the process that we have is there's capacity to do baseline testing, but you don't necessarily have to do the baseline test. It kind of, we have flexibility within the process that really the key things is the logging of the concussion and the notification. The rest of the information that happens around that is gravy. And the cool thing we have with the app, which we really worked on this year, is letting a physio like Kirsten, who can put some notes into the logging of the app so that when the GP sees it, they can know that Danielle ran into the post, I was fine, but then at the end of the game, I chucked my guts and couldn't remember where I parked my car. And that information can then go to the GP. So when I turn up on Tuesday and try and pull the wool over their eyes saying, oh yeah, no, it's fine. They know actually you vomited and you couldn't remember where you parked your car. So obviously you were concussed. So it's just trying to, because we know players are really motivated to play and tend to, you know, heart and hand, probably not make the best life decisions, trying to get back to playing and trying, you know, that's their motivation. So it's trying to put some safety nets around them to say, hey, actually, just cool your jets, make sure you're fully back to health and that you do the right steps to make sure that you're recovered before you go back.
That's fantastic, fantastic. Well, I think, I'll put it up there going once. I'm going to start like an auctioneer. Going twice. Oh, there we go. You got in there, Marama.
There we go. Oh, tēnā tātou katoa, kia rana katoa so. Ngā talofa lava ma loi lelei. And yeah, lovely to Danielle and Kirsten, and of course, obviously Brett, not that you said much, but that's okay. And Graham. And yeah, thank you very much for your knowledge, and Sean, thank you for opening. I'm the chairperson for the Upper Central Zone, and one of the things that I've noticed just walking through the grassroots is, I suppose, from a grassroots perspective, we have what we call match managers sheets, and upon speaking with district chairs, looking at how we can also influence concussion or HIA through actually reporting it on those sheets. If you get an opportunity, there's two grand finals that you can actually watch of rugby league, and there were quite a lot of high tackles that were called by the referees, and I suppose from a point of view, when we say that the referee cannot, you know, because I've got a lot of other things to do, but yet they have the ability to see what a high tackle is in the game. So there's actually little points within the grassroots that we can affect, influence. I think from a grassroots level, there's definitely an ability to strengthen the districts around concussion in workshops like this. And also our people that are volunteers to support in those roles as well. I suppose because we've had the ability and to be able to get onto sporting, in discussion with some of the chairs, we've spoken about they've got to put in the team cards anyway. So this is an opportunity to share with Sporty that there's been so many concussions in the game. And then so there is an opportunity to send such a red flag out, but our people don't, because it's normalized. It's quite a normal thing. The harder the hit, the greater that you've accomplished, and it's a celebration. It's really crazy, to be honest. I've never, you know, I love rugby league, but yeah, we celebrate the harder the hits. So yeah, I think there's real good opportunity, that blue card, for our people to really stand up and be able to share that, you know, we want to be in the game longer, but we also want our young men to be able to have a prosperous life post rugby league. I have 3 sons that play. I'm very mindful of whether or not they get an HIA or concussion. And I'm happy to say at this point, I've only had one that has had a concussion, but it still worries me to today. And they're in their mid-20s. So I think there is definitely opportunity from a zone perspective in the community that we can do a lot more in the districts. It's just how we sell that to our community, to say that we're growing good men. Just because they don't make a big hit and get hit on the head doesn't mean that they're not great league players. So it's changing the view of what is the future of our code, rather than big hits, what makes you a great player. So yeah, that's just my comment.
No, for sure. And what they
I don't
do
know.
with some of the blue card stuff in the PUs is, with rugby, is they just note it. So they put BC beside the player's name on the game sheet. And then when that goes back to the union, an email or a letter goes out from the union to those players and the club saying, you know, Danielle sustained a concussion. She can't play till we see a medical clearance, or she's down for those 23 days. So, you know, I know the different PUs have different systems, but, you know, it can be something as simple as that. And I think really, to pick up on what you said there, is it's coming from a place that we care. And I think, you know, the more people are across that, I think the easier it is to stand up and say, I don't think you're okay, you need to come off. And yeah.
So I had a few trainers who are not trainers, or we haven't had first aiders, when you're trying to put a young man off because he's been hit and you can see that he's on his feet, and that's a straight sorry, he's off the field. And then you're getting the boo and the jesting from the sideline saying, just leave him out there. Yeah. So it's not even about, it's a whole culture change around how we are in those spaces. And
I think Madam,
yeah.
Sorry, Madam, I think some of that also needs to come from the top, from rugby league internationally, not just here. And rugby union certainly have been much more strict recently than they ever were for anything above the shoulders tackle. Now that doesn't take away from concussions, because also knees hit heads and heads hit hips and things, but certainly the direct shoulder to the head is really been, you know, come down hard on within rugby. But again, and that's a cultural thing, and a thing that they've really started to work on in the last couple of years.
Yeah, so thank you, Marama. So obviously we'll be in the upper central zone. Just to give the rugby people a bit of context, it is upper central is sort of Waikato, Bay of Plenty, down the coastline, and I know I'm missing one.
Hawke's
Waikato.
Bay.
Yeah, Hawke's Bay will fall under our mid central zone.
Hauraki, Gisborne, Tarawhiti, Waikato, Bay of Plenty, and coastline.
There we go, Hamana. So quite a big area, and Hamana there, he's one of our leads in those areas. So again, thank you very much. So we might wrap it up there, eh?
Cool. Well, thanks very much, guys. Thanks for having us. And thanks, Brett and Kirsten and Graham, for jumping on. Really appreciate it.
Absolutely.
good.
Thank you, everyone. And we'll keep in touch, and I'll send out a follow-up email as well.
Thank you all.